I want to welcome folks to the Learning Collaborative seminar. I hope folks are staying dry. It is pouring here in Little Rock, and I guess the severe weather is coming here, and so I hope that folks are safe and dry in all of this. We've got we're going to spend a big part of our webinar today talking about NCQA, or the National Committee for Quality Assurance, PCMH certification or recognition program. And we've got Dr. Stacy Zimmerman, who will be talking about her experiences with implementing NCQA. I'm really excited to hear about their experiences, and we can certainly talk more about what we as a chapter can be doing to support folks who are interested in NCQA recognition. Kristen, go ahead. Next slide, please. Some reminders for this teleconference. Please mute if you're not speaking, but so this will cut out any extraneous noises, but please do not put your phone on hold, otherwise we can hear all of your hold music. Our objectives today, I'm going to start with a little bit of PCMH update for next year, as well as an update about the CQN ADHD project, and then we'll get into the NCQA certification process. Next slide. Okay. Our webinar, as well as our peer-to-peer support, is being provided by Arkansas Medicaid. Next slide. These are your chapter officers, and under PCMH update, go ahead and give us the next slide, Kristen. Okay. So first is a reminder about the end-of-year deadlines that we have facing at the end of this calendar year. So if you haven't looked at your 24-month attestation metrics on your AHEN portal, there are some things to be able to document. The first is use your EHR for care coordination. The second is to enter in your findings about a reassessment of your operations of practice and your opportunities to improve. Here's some questions that it says specifically not required to answer regarding practice transformation activities. There is an area where you have to attest about being able to extract clinical data from your EHR. Now, hemoglobin A1C and blood pressure are not strictly pediatric metrics. You have to be able to document that you can do data extraction. And this gets into the idea about doing more and more population management and using clinical data to help help us do population management. The final thing is to as a reminder that care plan attestations are also due at the end of December, and that we have to do 2 care plan attestations for our high priority beneficiaries and get to 80% for our second attestation. Are there any questions about the end of the year deadlines for 2015? I also am interested in knowing if folks have specific questions or concerns about them that we can relay, or we can discuss in a chapter level and relay over to Arkansas Medicaid.
Hi, my name is Brianna Wilton. I just wanted to see about, I've heard a lot of times about the Arkansas Medicaid website. The EPSDT information is not always updated for the claims, because we will have a claim processed 6 months ago for an EPSDT, and then it does not actually reflect on the Medicaid website. It will still show that the patient's last EPSDT was 2 years ago.
Okay. Are you referring to which website are you referring to? Do you refer to the AHEN website, or are you referring to the AMII the AMI website?
I'm the Arkansas Medicaid.
So the one
website.
the one that you go through Arkansas Medicaid, the website, the one that you go through the Arkansas Medicaid website.
Yes, because I know part of our 24-month attestations, we're actually doing 12, 18, and 24.
Oh, okay.
So we have the preventative care, and one of those things that I thought we should touch on is the EPSDTs, you know, making
Right.
sure that we get those in. But if the Arkansas Medicaid website does not always update correctly,
Yeah.
then that kind of puts us in a place of how
Yeah.
do we know when it's correct to send the patient this information or not?
Yeah. Yeah. So I have a few thoughts for you that, and I actually would like to follow up with you offline. But let me give you some thoughts on that. I have gone through our own website. You know, as a children's hospital provider, I've gone through a number of. I've accessed that website a number of times and looked at the accuracy compared to what we have. You know, my experience is that a lot of times it's pretty accurate, but there are times when it's not accurate, and what we need to do is figure out, you know, is it where the break is. There is going to be a lag of some sort with any data that comes up because of how long it takes for a claim to be processed. Obviously, if something happened 2 years ago, it should be on there. And then there's a matter of trying to track down where the break is because they're going to list whatever claims are on there. And I've found things from, you know, sometimes there's providers dropped on and off. Sometimes it's been that yeah, sometimes that, you know, it wasn't coded the way that you would expect, and I think it could be any number of things. And so I would like, if I think the main thing to do is, you know, we can work with you in Arkansas Medicaid to try to track down, if you've got a list of, let's say, 10 kids, I have found that they have been excellent at tracking down exactly why there's a discrepancy between what you have and what they have. And we should be able to figure it out from there. So my suggestion is, I'm happy to follow up with you offline about that. One of the things that you'll see in one of my later slides is that data transparency and accuracy is extremely important in payment, in practice transformation and value-based payments, which is where everything is going. And I commend you for looking at the accuracy of your own data, and that's something you need to do. Kristen, are you there? Can you perhaps facilitate following up with Brianna Wilton?
Yes.
Okay. Can you facilitate a follow-up with us, and then we can go from there?
That sounds great, definitely.
Okay, Brianna, how does that sound as a next step? Is pull about 10 kids, or 5 to 10 kids, and we can go through. We can work with you to try to track down what happened to those kids.
Okay, awesome. And, you know, I was thinking about even labeling our own system so that way if it doesn't reflect on the Arkansas Medicaid, at least we have it reflecting on our own.
Yeah, and I do encourage that because, you know, if, you know, you can always get your own data much faster than relying on on claims just because it's real time. And I think the idea is that it also allows you to have a check on making sure that everybody's got the same data because you've got access to your own medical records and you know what you did. So I commend you for doing that. I think the next step is we need to track down where the difference is between what you have and what the claims are.
Okay, awesome. Well, thank you.
Okay, we'll follow up with you on that. Any other questions? Great. Okay, the next slide. Okay. Over in the past webinar, so 2016, one big difference is that the care plans, so attestations for 2 care plans for high priority beneficiaries. That is the only practice support metric that will continue. Otherwise, we are to continue the activities that we're doing now regarding payment transfer, practice transformation and payment reform. And I'm going to get into a little bit more about the national activities that are going on that I think we just need to be aware of. There is a couple of new things that we've talked about in the past. One is that we are moving towards outlining what a strategy may be to increase our immunization rates. As I mentioned before, immunization rates in this state tend to be near the bottom compared to other states nationally, and we've definitely got a number of things to work on. You should be aware that there is a number of immunization activities on the state level that should help us with immunization rates. And one thing that I have done on the chapter level is make sure that we make the needs of providers known regarding immunizations. For example, I mentioned that one of the biggest things is to make sure that data for the immunization registry is easily accessible on a two-way information exchange. And then the other thing, of course, is VSD requirements and payments for immunization. So that's something we are working on at the chapter level. The fourth bullet point is, I mentioned earlier, is to be able to extract data from the EHR. And one thing that you're going to want to, one measure that is in there is being able to document that you can pull height, weight, and BMI data for kids over 3 years of age. Next slide. So what I've listed here comes off the Human Improvement website has updated 2016 provider manual along with the supplement that contains some of the technical details of what is how the metrics are calculated. And for the next two slides, I've listed the quality metrics and the targets for the 2016 performance period. So you'll notice that the number of metrics have gone up, and some of that is because the metrics now reflect, excuse me, some of the support metrics have moved over to shared savings practice metrics. So I want to highlight a few things on here. So metric 1, high priority beneficiaries that have been seen by any PCP within the PCMH at least twice in the past 12 months has now gone up, it will go up to 80% in 2016. You'll see metrics on inpatient hospital stay. There's the wellness, well-child visit metrics. You'll see that the 3 to 6 year and the 12 to 21 have gone up a little bit. Asthma medications hasn't changed. ADHD, I'm a metric 8. ADHD hasn't changed. Metric 9 is new, and that is actually very similar to episodes of care. That's upper respiratory infection, which is that if you have respiratory infection, of course, make sure that you are treating upper respiratory infections appropriately. Next slide. So these are the remaining ones, and you'll see that most of the new ones are for 18 and over, except for metric 15, which is percentage of patients 3 to 17 years of age who have outpatient visit with a PCP or OBGYN who have evidence of height, weight, and body mass index during the measurement period. Any questions? Okay, next slide. I want to talk a little bit about what we're seeing on the national level. I attended the Patient-Centered Primary Care Collaborative meeting last week in Washington, D.C. That is a group in D.C. that has brought together a lot of stakeholders on the national level regarding promotion of primary care, particularly within as we move towards patient-centered medical home rollouts. And I've compiled a few speaking points that was by Patrick Conroy at CMMI, Center for Medicare and Medicaid Innovation. He's a pediatrician, and I'm also pulling some of the information that the Centers for Medicare and Medicaid Services has. So CMS, so first of all, the mantra for healthcare reform has moved towards better, smarter, and healthier. So better care, smarter spending, and healthier people. We talked about the triple aim. This is really where the triple aim has moved to: better care, smarter spending, and healthier people. And this is something that we all want to achieve. CMS, when I talk about the CMS goals, they're actually talking about Medicare, but this is where payers are all moving. They want to move towards alternative payment models, which is accountable care, shared savings designs, basically a lot of what we're working on in Arkansas. They want 30% of Medicare into alternative payment models by the end of this year and 50% by 2018. Total cost of care considered advanced primary care, which is basically what we're doing under the PCMH in Arkansas. The second bullet talks about that for traditional Medicare, traditional fee-for-service, they want 85% of its quality or value by the end of, actually that should be 2016, my apologies for the error, and 90% by 2018. And the reason I put this up here is that payment models for both the federal government, state agencies, and private payers are all moving towards alternative payment models and value and quality metrics. And we are really ahead of the game in Arkansas. And the 3 lessons learned that I picked up from the talk in Washington, they made 3 very important points. The first is that strong clinician leadership drives change. And so when you're looking at meeting metrics and engaging in practice transformation, you really have to have strong leadership from the clinicians. The second bullet point is data transparency and feedback are critical. So this gets back to, Brianna, your question. The data needs to be as transparent as possible between the providers and the payers, and feedback about the accuracy and the timeliness of the data is critical to moving this forward. Because these programs are all still relatively young, defining the metrics and defining the data timeliness and accuracy are all things that need to be worked on. As you all know, there have been a number of metrics that we at the chapter level have helped Medicaid clarify over the past year, including the input for the metrics for the 2-visit high-priority beneficiaries in a hospital discharge 10 days over the last year. And that's an example of the partnership that we really need to make sure that this program works. The third thing is that clinics who engage longer in transformation tend to do it better, so that if your clinic is fairly new, the changes will tend to happen at a little bit slower pace than a clinic that has been doing it for longer, which to me means that, you know, if the longer a clinic has, the amount of time a clinic spends in transformation really does make a difference. So the quicker that you have engaged in it, the better. And if you're thinking about engaging in transformation, the sooner you do it, the better position you will be in to be able to meet the payment needs and the payment structure that will happen going forward. I do want to emphasize that all of this is really designed to help us take better care of our kids and to be appropriately compensated for the services that really do make a difference in health. So that the traditional fee-for-service model, which is not necessarily promoting health, is really being phased out. And payment models which value health and minimizing preventable health encounters is really what's on the table now. Any questions on this slide? Okay, next slide, Kristen. Kristen, do you want to talk a little about our ADHD project? I can talk a little about it as well, but I wanted to give you the opportunity to talk about it if you like.
Sure, and I'll keep it short because I know that Dr. Zimmerman's presentation, I believe, is about 40 minutes. And I just want to say thank you for those who have already enrolled. And if you haven't clicked on that enrollment link that I sent you, if you could please do that, that would be great. And let me know if you need me to send it one more time. And to some of the other clinics that are still considering, I just want to also remind you that this is a project that is a huge time saver for your practice. The MeHealth portal software is incredible, and usually it's pretty expensive per provider, and it's free with this project. And this project gives MOC that can be used for 2016 and beyond. And if you would like me to see if Dr. Kuo can speak directly to any provider about specific questions related to enrolling in this project, I'd be happy to try and set that up. Dr. Kuo, were there things you would like to add about our ADHD project?
Only that I think that this is an excellent project. It's a CQN, the Chapter Quality Network. I've been working on some strategy and a paper with them. This is the CQN. was really ahead of its time in talking about patient registries, chronic care management, and it's really nice to see a lot of this work not just come into place to really meet payment practice transformation and payment changes. So, the use of electronic software to facilitate online assessments of Vanderbilt, I think is terrific, and I would encourage folks to take a very close look at enrolling in this project. Okay, next slide. So let's talk a little bit about NCQA, and I'm going to turn it over to Dr. Zimmerman. NCQA is really the first national PCMH recognition program. They started in 2008, and it's the largest recognition program in the country. And the reason I wanted to have us talk about NCQA is that, the idea is to provide a national recognition to encourage practices to use the blueprint to engage in practice transformation. And the idea is also to tie recognition to enhanced payments. This has been relatively slow in coming out around the country, but Arkansas Blue Cross Blue Shield is providing additional support payments for practices that are NCQA recognized, different payments between level 1, 2, and 3. And my discussions with them is that a number of other private payers will start to do so very shortly as well. So given that also around the country that more and more payment plans are starting to look at NCQA for enhanced payments, we figured this would be an excellent time to go over the program itself. Next slide, Kristen. So this slide's a courtesy of Arkansas Blue Cross Blue Shield. I have them to thank for providing a number of these slides. So under NCQA PCMH recognition, you certify your achievement in a number of areas that earn you a number of points up to 100. If you certify anywhere between 35 to 100 points, you can get different levels of recognition between 1, 2, and 3. And there is a 3-year recognition period that you would then use to also get your enhanced payment if a payer recognizes your certification. Next slide. So there are 6 broad standards. You can get points within these 6 standards: patient-centered access, team-based care, population health management, care management and support, care coordination and transitions, and performance management and quality improvement. And within each of these standards, there are must-pass elements that you have to pass in order to qualify to getting points within those standards. Next slide. So these are the must-pass elements. So your first element, so your must-pass elements include appointment access, which really centers around availability of appointments and same-day appointments and 24/7 access. You have to do team-based care as an element. Use data for population management. Element B, or PCMH standard element B, is care planning and self-care support really centers around defining a high-priority population and developing care plans and self-management support for that population. And then the last 2 are referral tracking, as a must-pass element, and then continuous quality improvement, which is use of data to drive quality improvement, is also a must-pass element. And I think that's the last slide. Okay, Dr. Zimmerman?
Yes, Dr. Close.
Yes.
I'm right here.
Welcome. Thank you so much. It's all yours.
Thank you.
Very excited.
Thank you for having me. Welcome, everybody. I love the far side, and I think this cartoon really touches on actually what Dr. Quo just said earlier about the strong leadership that drives change. And that's exactly what this cartoon is saying. Arkansas is really going through a transforming change with PCMH as it looks like the model of the future. So I think for our state today, it's very, very important that we as leaders and innovators need to work to help each other in the state move through this process of change so we don't end up having clinics like these guys. Next slide, please. My name is Dr. Stacy Zimmerman. I'm board certified in internal medicine. I'm also a pediatrician. Next slide, please. And Kristen, we can skip through the next few slides. I'm in Clinton, Arkansas. Go ahead and skip the next two, please. We'll save some time. And this is my clinic, Ozark Internal Medicine and Pediatrics. We have 10 full-time employees, 1 APRN, 4 part-time employees. We also have 4,000 active patients in our registry. We have a Facebook page and a website on the next slide that serves our patients. We have a patient portal. The reason I'm showing you this is because most of you probably already have websites and Facebook pages. And this is very, very important for NCQA because all of this stuff is what you will be using to document many of your factors and your elements in NCQA. So I want you to remember this. That's why I'm showing these slides to you, because this is low-hanging fruit. We do our diabetic education on our website using live diabetic interactive patient webinars. Great way to attest for NCQA. Now, we are a level 3 NCQA patient-centered medical home. We completed our NCQA PCMH renewal the end of October. Our clinic was recognized 3 years ago as part of our participation in the Blue Cross Blue Shield pilot program of Arkansas. Next slide, please. So what is NCQA? It's a not-for-profit organization. I think that's very important. And as Dr. Quo said, it was founded in 1990. And these are some slides I got from Blue Cross Blue Shield also. Let's skip a slide, Kristen, because Dr. Quo covers a lot of this. Again, these are the standards of NCQA. Yeah, and stop here. So why NCQA? Well, first of all, they're non-biased. They're a third-party vendor that reviews all documentation and determines recognition.
Look forward to providing your child quality.
They support population management, which really is very much in line with all of initiatives in Arkansas. And they have clear guidelines and requirements and expectations. And furthermore, I've been told that Arkansas will actually have 1 reviewer assigned to the state. The next slide, Kristen. And this is the Blue Cross Blue Shield slide. As of January 2016, our clinic will actually earn an $8 per member per month for level 3 recognition. Now, you must meet all of the must-pass elements to achieve recognition. I know Dr. Quo showed that earlier. But in my opinion, most clinics who participate in the Medicaid patient-centered medical home should meet at least level 2 status. Because remember, if you meet all the must-pass elements at greater than 50%, you only need 35 to 59 points to meet level 1 status. Now, renewal is every 3 years. It is much less cumbersome and really just consists of demonstrating that you meet the must-pass elements. So I didn't think it was that difficult. Next slide, Kristen. And this is the key to NCQA, and I'm going to come back to this several times. This is, I think, the most important slide. And this is the must-pass elements that Blue Cross Blue Shield publishes for us. I usually recommend most clinics start out with Standard 1 since it's the easiest to prove. It is the easiest to document, and it's the easiest to go through the process. It's the same-day access standard. It also contains after-hours appointments or after-hours access that you have to demonstrate. No-show appointments. No-shows. You have to document those. You have to document alternative appointments if you have them available. And it's a pretty straightforward process in showing that you do a PDSA for your no-shows and that you track it, and showing how you track your same-day appointments. So I always suggest everybody start out with Standard 1. Next slide, Kristen. Okay, this is a really good slide that I wanted to show you. Now, this is only page 1 of a very long document that AFMC was very kind to let me show you today. How does NCQA compare to the Medicaid, patient-centered medical home, and all of the other initiatives? Well, this slide demonstrates how meaningful use, NCQA, PQRS, and CPC actually compare to each other. And I'm showing you this because CPC, as we already know, has already aligned with all the Medicaid patient requirements in the Medicaid patient-centered medical home. Now, NCQA, if you can put your mind around it, captures all of the CPC, meaningful use, and Medicaid patient-centered medical home requirements. Now, this crosswalk uses the NCQA 2011 standards, which really are not much different than the 2014 standards, except for the addition of the meaningful use 2 requirements. I really, really hope that AFMC makes one of these for the 2014 NCQA standards, as I find this document, as busy as it is, very handy for those of us who participate in multiple initiatives. Next slide, Kristen. Kristen, can you hear me?
Yes, sorry, I've already put it on the next slide. I don't know if there's sort of a lapse. Can you see it? It's the
I can see it. Sorry. This is just an example of the 2015 CPC quality measures, and I just wanted to show you how similar they are. And we'll go ahead and go to the next slide, Kristen. So when I think of all the clinical quality measures and the reporting requirements, I like to use this visual. NCQA recognition is an encompassing and extensive alignment of all of the other reporting programs. The fact of the matter is, if you meet NCQA, demonstrating for any one of the other initiatives is not all that difficult. I'm a one-provider practice. I have one nurse practitioner, and NCQA allows me to compartmentalize all of the initiatives, therefore limiting all that repetition that I was doing before. I really think an outside national standardized system like this could be a very powerful asset for the clinics of Arkansas. Next slide, Kristen. So what is the process of NCQA recognition? This is the homepage at ncqa.org. This is where you go to get the free PCMH 2014 standards and guidelines. There, inside this box on the homepage is a link to the online application process, which you do first, and then there's also a link to the ISS tool, which is where you document your site survey. So I often get a question, should I attend webinars? And I say yes, I think a few are okay if you want to get yourself familiar with the process and the standards. But I would not recommend using them as a guideline to complete your survey tool. I will be honest and disclose, I'm a true double-blinded duck. I've been through NCQA twice, and I have never attended a webinar from NCQA or a seminar. I did participate in the Blue Cross Blue Shield Patient-Centered Medical Home Pilot Program, and I had formal coaching with a vendor, but that was it. So my recommendation is that you should always follow and default to the 2014 PCMH standards and guidelines. That is what needs to be your Bible, and I'm cautious about not letting any experts trip me up. Next slide, Kristen. This is the same web page at ncqa.org. It's a great algorithm for you to go through the initial steps to get started. My only suggestion here is to get the ISS tool as soon as you submit your application. They recommend you get the ISS tool further on down the process, but I personally got my ISS tool as soon as I got my application. Next slide, Kristen. This is actually from the ISS tool instruction manual off ncqa.org. You got to really dig for it to find it. But you'll see With the ISS survey submission, there is no time limitation. So once you get your online application completed, you can purchase the ISS tool, and there's no time limit for you to submit. So you can have that tool for 7 months, 8 months, 9 months, get familiar with it, upload documents, figure out how to use it, get comfortable with it, toggle back and forth between the standards and guidelines that are available on the ISS tool as a reference, and really do a good job putting your documentation into the tool for your reviewer. Just got to be careful of one thing, and I would take very great care not to click on the Submission tab, which is on the top left-hand screen when you open up your ISS tool and you log in. I bought my online application last, I think, February for my renewal and my ISS tool the same week, and I submitted the end of this October. So I had it open for probably at least 7 months. Next slide, Kristen. So where do you start when it's time to tackle and document this granule? You've done the online application, and with your standards and your guidelines in your hand, you're ready to start documenting the process in your NCQA folder on your computer. First of all, remember, you are documenting processes that you already probably have in place in your clinic in front of a total stranger. So you want to lay out a clear visual path of your clinic model for the reviewer to follow. Start with the must-pass elements and start with standard 1, but I do not recommend you proceed in numerical order, and I will get to that in a minute. I recommend you not go standard 1, 2, 3, 4, 5, 6. Start the process early. Complete the online application process and purchase the ISS tool as early as possible, 6 months prior to submission if you can. Next slide, Kristen. You need to plan. How much time do you need to plan to get certified for NCQA and get recognized? Well, one study showed that initial recognition took 300 hours. Another one showed that and renewal took about 150 hours. I'm more like, since I was a one physician practice, 350 to 400 hours for my initial recognition, and it took me closer to 200 hours for my renewal. You need to plan for at least 300 dedicated hours for the process. To not overwhelm yourself, I would plan 1 year to gather documentation and data for the initial recognition and 6 months for a renewal. Next slide. So how do you organize your documentation on your computer while you are gathering it? Okay, you have your free standards and guidelines. You're going to have that in a folder. You're going to have your online application process finished. Now you need to organize your folders in documentation in your NCQA folder on your desktop. You're going to have that folder. Within that folder, you'll have folders labeled Standard 1 through 6, Standard 1, Standard 2, Standard 3, and on down for each folder. Within Standard 1 folder, all of your documentation will be labeled like this. Each document will have this label. One document will say Standard 1, Element A, Factor 1. Then the next factor will be Standard 1, Element A, Factor 2, and on down. Furthermore, you will organize your documentation in order of importance. NCQA on the tool will ask you if that document is a primary document, a secondary document, or a supporting document. So you'll have to choose. So I tagged each document as primary, secondary, or supporting when we put it in the folders. You really do not want more than 3 documents per factor. That's quite a lot. I try to keep it 1 document per supporting factor. Start with the most important items and work your way down to the details. I started with the critical factors and then worked my way out. And that way I was sure to get the most important points. Next slide. So remember, this is an example of one of my actual Standard 3 documents. I know this is probably hard to see, but I wanted to demonstrate how important it is you label your documents and use call-outs clearly to illustrate your screenshots. Remember, you must de-identify all patient information or NCQA will delete documentation without reviewing it at all. Your goal with these documents is to control your reviewer's visual path through the data. Next slide. This is another document from my ISS tool from Standard 1. This demonstrates my same-day access. I'm showing you this report because it's always preferable to use reports from your EMR to support your documentation. Doing so reinforces to the reviewer that you have a sustainable process in place. It also looks good 3 years down the road when you produce the same report on your renewal. Next slide, Kristen. Okay, I keep going back to this. This is the key to NCQA, the must-pass elements. Remember, you only have to have 35 points to meet level 1 recognition. I would start with Standard 1, then go to Standard 3, then move to Standard 6 while I was putting my documentation together. Why? Because Standard 1 is the easiest one to tackle first. Then Standard 3 involves tracking all of your clinical quality measures and your data. And Standard 6 involves demonstrating improvement on that data around 12 months prior to your submission. So it seems to flow better when you do it in that order. Next slide, Kristen. This is a piece of an example from my ISS tool Standard 3 using data for population management. What you need to remember is after you demonstrate that you can use your data for population management, all of your clinical quality measures here, you must take the measures you track from Standard 3 and demonstrate improvement using these measures for reports you've generated 12 months prior to submission in Standard 6. Next slide, Kristen. I put this slide in to remind you that more data is not better when it comes to NCQA. Try to keep it simple, try to keep it clear, and try to keep it concise. Remember, your reviewer could be a retired nursing care manager or a statistical major from NYU. Next slide. This is the model of our small PCMH. It is a circle of team-based processes with a goal to support a sustained patient-centered care for improved outcomes. We start with checking our data frequently to adapt change to our practice. We don't expect huge improvements, and we try to create reliable workflows because we're a really small office. Then we use our PDSAs to drive our sustainable change because sustainable change is the key. As a small practice, we just can't depend on local heroes to we have to make an effort with everyone. Messages go out to everyone. And this is so important to allow customization when you're small, provided the core elements and improvements are clear. We use team strategic review of the scope of change. For instance, our clinical staff will review our scope of change, and then the front office will, and then we get together in our team meetings for team tracking and monitoring of those processes. And the hardest thing for me of all is sustaining the gains with the infrastructure of staff to support them. Sustaining the infrastructure of staff to support my processes in place is why NCQA recognition is so important to me. We need that increased PMPM that Blue Cross is offering for NCQA recognition to sustain our patient-centered medical home. Next slide, Kristen. So finally, in your quest for NCQA, I have some tips for success along the way. First of all, assume the reviewer does not know.
Because I got stuff that I got to get out because we got patients to do.
Screenshots and visual reports. Demonstrate each step of the process. Don't skip steps. Update your employee training manuals now to match the NCQA guidelines because they must be in place 6 months prior to your submission. Use the worksheets in the ISS tool for documentation. Your reviewers are used to using those. It is their comfort zone, and don't stray outside of those. Pay close attention to the document reporting periods on the ncqa.org website. That trips clinics up a lot on working on Standard 6, and do not deviate from the 2014 standards and guidelines. And get your ISS tool early as possible and start using it. Get yourself familiar with it. And finally, don't be afraid to admit failure to your reviewer. For instance, our clinic, we actually failed to demonstrate an improvement in our vulnerable population measure. And we were pretty upset about it. But we explained in our ISS tool the reasons for falling short and failing this measure. And even though we failed it and we knew we didn't get points for it, I think it demonstrates to the reviewer that your practice proactively self-critiques itself with its processes, and it really makes your clinic look good. Next slide. Okay, I'm going to stop here because I wanted to allow some time for questions. Thank you for asking me to speak today.
Thank you so much, Dr. Zimmerman. That was an excellent presentation. And does anyone have questions for Dr. Zimmerman?
Hey, this is Dennis Quell. I'm going to lead off with a question. Stacey, this is really amazing work that you've done, and I'm so glad that you had the opportunity to present to us today. As we do kind of a selling job on how NCQA is something that practices may consider, can you talk about a little bit about how you decided, since you were one of the earlier adopters in the state, about why you decided to do NCQA and how you think it impacted your practice, how it improved your practice?
Oh, sure. Thank you. I know this is a really rapid presentation, and I apologize for that. I wanted to be sure and get finished so people had time for a little bit of a discussion. But I was very frustrated with my practice about 5 years ago. I did not like my flow of my day. My routine was fragmented. My patient care was fragmented. My employees weren't happy. And I decided there had to be some major change in my workflows and how there had to be a better way to practice to where I could take control of my practice back. I felt like my practice was running me, and I was not running my practice anymore. And so having the opportunity to participate in the Blue Cross Blue Shield pilot program really was an altering experience for our practice. And I can't tell you the difference now, because we have procrastination is a word that's not allowed in our practice. And for a physician, and you would think I would be crazy, crazy busy, at 5 o'clock, everything is done. Our charts are done, our messages are done, our prescriptions are done. I have nothing to sign off on, and it's so nice to not have that stress the next morning when you get up, to know you just have to have a cup of coffee when you get to work. There's nothing left to do. And it's that way for the entire staff. And it's because we have the organized workflows in place, and a transformation takes place. The patients are happy, the employees are happy, everybody's happy to show up in the morning for their huddle, and they want to be there because they want to do a good job with the patients and know what the plan is. So until you experience it, it's kind of a life-altering experience you have to experience, but I can't imagine going back to the old way, the old practice style.
Thank you. That's fantastic. And to drill down a little bit more, you're really referring to NCQA in kind of your experience offered a structure to be able to get to that point where you were able to address your workflows, assign care team roles or roles for folks to engage in population management. I mean, there's referrals, tracking, there's test tracking. With the certification process, the impetus, or do you feel like there was other additional things that you did, which the NCQA is more of a recognition rather than the catalyst?
Yes, NCQA does force you to go through processes with your staff that you would not normally do. And in those steps, you do realize that these are good things. The care management standard, for instance, you have to go through so many detailed steps, and it's so organized that it further organizes a structure that you thought you had it down.
Yeah.
You thought you had it, and then you do the organized structure, and you think, no, I didn't have it down. It can be done better, and so it does make a good clinic better. It makes you really critically think about how you're doing things in your practice, and I think even going through the renewal was a surprise, because we actually implemented lots of new things in just going through our renewal. And
so you started out in the 2011 guidelines, and your renewal was the 2014 guidelines?
Yes.
Okay.
So that was a change for us, because
Great.
we started out with 2011, and then we had to renew with 2014, and 2014 was actually quite different, a little bit different. But it was nice because we got to add, you have to always grow. You have to always change. You have to always add new things. And to have that kind of standardized guide, to do that, but yet have the autonomy as a practice to do it your own way, I like that. I like that better than an outside structured system. And NCQA allows for that autonomy, but yet you can build it from the inside as long as you follow these guidelines. And it's an impressive system.
And you submit all the documentation. There's a very small chance that you would also get personally audited.
Yes, a 5% chance. 5%
get audited. Of the rest of it is documentation that you submit, and they review it.
Yes.
Okay.
Yes. So 5% of the clinics that submit will get audited.
Okay. Folks, other questions for Dr. Zimmerman?
I have a question. This is Cheryl Arnold. Dr. Zimmerman, great presentation. I just downloaded my ISS tool this morning, so I'm just getting started. So you were recognized, you were NCQA recognized prior to Arkansas's implementation of the Medicaid PCMH. So do you feel like that the fact that you had gone through NCQA made hitting the metrics for PCMH easier for you? Therefore, part two of my question would be, do you feel like that for those of us who have been participating in PCMH that it will make the going through the NCQA process a little easier than someone who was starting from ground zero?
Oh, yes, absolutely.
Okay.
I do. It was very easy for me to meet the Medicaid PCMH requirements. In fact, it did not take much effort for us to meet that at all. We were already in CPC, and we were meeting those requirements. And so we have not really, I hate to say this with Medicaid on the phone, put forth much effort. Our total cost of care for 2014 was, I think, around $1,500 per beneficiary, which was very low.
That is very low.
And our measures were, so from what Letch tells me, so excellent that they had to cap us at 10%. So we were off the scale on our measures. So we outperformed, we did very well. And so as far as feeling prepared for the Arkansas Medicaid patient-centered medical home, I think we were over-prepared. Now, going into it green and not participating in any patient-centered medical home, yeah, NCQA would be very hard, and that was the situation I was in. But for you guys already being exposed to the Arkansas patient-centered medical home, and some of you to CPCEI, you're ahead of the ball. You really have a lot of these processes in place. It's just a matter of demonstrating them and proving them to somebody who's on the outside who doesn't know that.
And there is no on-site review unless you're chosen as part of their 5%. Everything else is just by submission.
Yes. Everything else is
The
by
whole
submission
process.
unless you're one of the unlucky 5% who wins the lottery and they come do an on-site.
Wow, well, you've done an excellent job.
Thank you.
I applaud you.
I think we got a couple more minutes. Okay. Dr. Zimmerman, I think if I really appreciate, very much appreciate, especially on behalf of the chapter, you're coming on and talking with us about NCQA. You haven't heard the last from us as a chapter regarding this NCQA, if that's okay with you.
No, that's fine.
About that, and yeah. Oh, actually, I actually just got a question. I actually just got a separate question. Sorry, I'm trying to pull this up. Okay, this is from Dr. Davis, who said that we're having connection issues. The question is, what do you use for reports regarding your EMR?
Okay, my EMR is EMDs, and I use the Crystal report system within EMDs. I know that there are better reporting systems with other EMRs, but I suggest if you are going to go through the NCQA process, you use your EMR's reporting system. That is really what the reviewers want you to demonstrate with. So hopefully you have a robust reporting system in your EMR, and that's what you can use.
Great.
They'll probably email them to us.
And then it's almost 1:15. I think that for Kristen, this presentation will be archived for folks that want to come and listen to it again.
Yes, it will be on our website, and I'll send a link out for that, and I'll also send a copy of these slides for everyone who is on gets my email notifications for this webinar.
Okay. All right. Great. It's 1:15. I think let's go ahead and sign off. Dr. Zimmerman, again, thank you so much, and for all, stay safe out there, and we'll see you next month.
Okay, thank you.
Okay. Bye, everybody.